Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Oceans, a randomized, double-blind, placebo-controlled phase 3 trial of chemotherapy with or without bevacizumab in patients with platinum-sensitive, recurrent epithelial ovarian, primary peritoneal, or fallopian tube cancer by Carol Agajanian et al. My name is Panagiotis Konstantinopoulos, and I am an attending medical oncologist at the Beth Israel Deaconess Medical Center and an assistant professor of medicine at Harvard Medical School, Boston, Massachusetts. My oncologic focus is gynecologic malignancies. Patients with epithelial ovarian, primary peritoneal, or fallopian tube cancer who experience relapse 6 or more months after the end of first-line platinum-based chemotherapy are considered to have potentially platinum-sensitive disease. A reasonable recommendation for management of these patients is rechallenge with platinum-based chemotherapy. In 2003, the International Collaborative Ovarian Neoplasm 4 trial, ICON-4, showed that the combination of platinum and paclitaxel was associated with an improved progression-free and overall survival compared to single-agent platinum in patients with platinum-sensitive relapse. Despite some methodological limitations, this study demonstrated for the first time that the use of combination chemotherapy with platinum and paclitaxel in the platinum-sensitive recurrent disease setting might do more than simply palliate symptoms, but might in fact be capable of prolonging overall survival. In the post-ICON-4 era, 2 additional platinum doublets were evaluated in randomized phase 3 studies in platinum-sensitive recurrent ovarian cancer. First, in the intergroup AGO-OVAR, NCIC, and EORTC trial, the carboplatin and gemcitabine combination was associated with a 2.8-month improvement in median progression-free survival compared to single-agent carboplatin, without improvement in overall survival or quality of life. Second, in the randomized phase 3 Calypso trial, the combination of pegylated liposomal doxorubicin with carboplatin was associated with a statistically significant 1.1-month improvement in median progression-free survival compared to carboplatin and paclitaxel. At the time of report, overall survival data were immature for final analysis. An important finding of this study was that carboplatin and liposomal doxorubicin was associated with a reduction in carboplatin hypersensitivity reactions, alopecia, and peripheral neuropathy compared to the use of carboplatin and paclitaxel. The results of the intergroup and Calypso studies established carboplatin gemcitabine and carboplatin liposomal doxorubicin as additional combination to consider for recurrent platinum-sensitive ovarian cancer. Bevacizumab is a monoclonal antibody against vascular endothelial growth factor alpha, with established single-agent activity in recurrent ovarian cancer with overall response rates in the range of 16 to 21%. In the first-line setting, 2 recently reported phase 3 studies, GOG-218 and ICON-7, showed that concurrent plus maintenance bevacizumab combined with standard platinum and taxane chemotherapy prolongs progression-free survival compared to placebo. In both studies, data regarding overall survival are still immature, and a quality of life benefit was not observed. In the absence of a quality of life benefit or an overall survival benefit thus far, incorporation of bevacizumab in first-line chemotherapy for ovarian cancer is not a standard recommendation, and this position was supported by the majority of the National Comprehensive Cancer Network panel members in the recently published 2012 NCCN guidelines. In the paper that accompanies this JCO podcast, Agajanian and colleagues report a randomized phase 3 study referred to as the OCEAN study, which investigates the role of bevacizumab when combined with chemotherapy in relapsed platinum-sensitive ovarian cancer. OCEANS was a double-blind, placebo-controlled trial of carboplatin and gemcitabine, with or without bevacizumab, in patients with recurrent epithelial ovarian, primary peritoneal, or fallopian tube cancer, who progressed 6 or more months after completion of frontline platinum-based chemotherapy. Overall, 484 patients were randomized in a 1-to-1 ratio to bevacizumab or placebo arms. Patients were required to have measurable disease and were not allowed to have prior chemotherapy in the recurrent setting or prior bevacizumab or other VEGF inhibitor therapy. Protocol treatment included gemcitabine 1,000 milligrams per meter square on days 1 and 8, and carboplatin AUC4 on day 1 of a 21-day cycle, similarly to the intergroup trial, and patients were allowed to receive up to 10 cycles of chemotherapy if continued response was documented. Bevacizumab or placebo, 15 milligrams per kilogram, were administered IV on day 1 during each cycle of chemotherapy, and then continued as single-agent maintenance until disease progression or unacceptable toxicity. At the time of progression, patients could be unblinded to treatment assignment. Primary outcome was progression-free survival, while objective response rate, overall survival, and duration of response were secondary endpoints. No quality of life evaluation was performed. At the time of final progression-free survival analysis, addition of bevacizumab to carboplatin-gemcitabine was associated with a statistically significant 4-month median progression-free survival advantage, 8.4 months for the control versus 12.4 months for the bevacizumab group, P less than 0.0001 with a hazard ratio of 0.484. There was also a statistically significant 21.1% improvement in objective response rate, 78.5% versus 57.4%, p-value less than 0.0001, and a statistically significant 3-month improvement in duration of response in the bevacizumab-containing arm. However, at the time of the second interim overall survival analysis, when almost half of the study patients had died, there was no statistically significant difference in overall survival. In terms of toxicity, there were no new safety concerns associated with addition of bevacizumab identified in this study. Known side effects of bevacizumab, including hypertension, proteinuria, hemorrhagic and thromboembolic events, occurred more frequently in the bevacizumab arm. 2 patients in the bevacizumab arm experienced gastrointestinal perforation, both 69 days after the last bevacizumab dose. Gastrointestinal perforation is an important safety concern for patients on bevacizumab, and its incidence has been reported to be as high as 11% in one phase 2 study of heavily pretreated platinum-resistant patients. Furthermore, in OCEAN study, 3 patients developed reversible posterior leukoencephalopathy syndrome. In 2 of them, the diagnosis was confirmed by MRI. The findings of OCEAN raise several important questions. First, how do we incorporate the carboplatin-gemcitabine-bevacizumab regimen into the current management of platinum-sensitive relapsed ovarian cancer? It is difficult to perform cross-study comparisons between OCEAN and either ICON-4 or the Calypso trial, especially since there are fundamental differences between them in terms of eligibility criteria, number of cycles of chemotherapy, as well as definition of disease progression. As an example, CA125 accessible disease and second-line platinum were allowed in Calypso and ICON-4, but not in OCEAN's trial. For these reasons, unless a direct head-to-head comparison of these regimens is performed, it is currently unknown whether carboplatin-gemcitabine-bevacizumab is superior to either carboplatin-paclitaxel or carboplatin-liposomal doxorubicin in this disease setting. A second question arising from OCEAN is, why did the progression-free survival advantage with a hazard ratio of 0.484 not translate into an overall survival advantage? One possibility is that subsequent treatment with bevacizumab or other salvage therapies after progression in the placebo arm may have led to equivalent overall survival between the 2 arms. Indeed, 31% of patients in the placebo arm in OCEAN study received subsequent therapy with bevacizumab. In this case, it may be argued that the OCEAN trial may not really reflect a pure comparison of bevacizumab versus placebo, but rather a comparison of concomitant versus sequential bevacizumab, at least in a sizable subset of patients. In other words, we may be comparing the immediate use of bevacizumab in combination with chemotherapy for relapse disease versus the latter use of bevacizumab, possibly even as monotherapy, after progression from second-line chemotherapy. Therefore, if overall survival between placebo and bevacizumab arms is equivalent, then it could be argued that there may be no advantage to the strategy used in Ocean's trial compared to reserving bevacizumab for sequential use upon subsequent disease progression. Of course, this argument does not recognize the potential value of the carboplatin-gemcitabine-bevacizumab combination as a very effective means of inducing tumor shrinkage, as reflected by an overall response rate of 78.5%, and the benefits that this may have on quality of life. Unfortunately, as quality of life was not measured as part of this trial, one can only speculate about this point. It is also interesting to note that the overall survival in the control arm of the Ocean study is significantly longer than would have been expected based on the intergroup study of carboplatin-gemcitabine. Eligibility criteria, protocol therapy, and characteristics of patients between the intergroup and Ocean studies were similar, and the progression-free survival in the carboplatin-gemcitabine arms were also similar, i.e. 8.6 months in the intergroup versus 8.4 months in the Ocean study. Nonetheless, the overall survival of carboplatin-gemcitabine alone arms was 18 months in intergroup study and 35.2 months in Oceans. Could this improvement in overall survival of the carboplatin-gemcitabine placebo arm in Oceans compared to the intergroup trial be accounted for by the fact that 31% of patients in Oceans received post-progression therapy with bevacizumab? The answer is unknown, and it's potentially misleading to make cross-study comparisons. But perhaps this observation suggests the clinical benefit of bevacizumab when used at some point in the management of relapse disease, be it concomitantly administered with chemotherapy as in Oceans or used as sequential monotherapy upon disease progression. We now have 3 clinical trials of addition of bevacizumab to cytotoxic chemotherapy, ICON-7, GOG-218, and Oceans, where a progression-free survival advantage has not thus far translated into an overall survival advantage. As overall survival data from these studies mature, it is important that we carefully look at these studies and evaluate the relative impact of post-progression therapies, as well as the possible change in tumor characteristics after bevacizumab therapy in ovarian cancer. Identification and validation of potential biomarkers of responsiveness to bevacizumab should remain a priority. This information will hopefully guide future clinical trial design and may permit better identification of patients who could benefit from a drug like bevacizumab. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.